everybody. I'm Pierre-Carole, one of the PGY2s for those that don't know me. Let's go ahead and get started. Today our topic reviews GI. And first off, I would like to say thank you to Dr. G and Dr. Paul Hein for helping me with this presentation. So our first question, we have a 72-year-old male that presents with 2 days of nausea and vomiting, diarrhea material, as well as abdominal pain and fatigue. He has a history of osteoarthritis and COPD, for which he takes over-the-counter pain medication. He was recently prescribed a short course of steroid for acute worsening of his pain. On exam, he started appearing, has epigastric tenderness to palpation, decreased range of motion in his bilateral lower extremity. His stool white is positive for melena with frank red blood. He's tachycardic, hypotensive, tachypneic, and study on 90% on room air. Which of the following is the most likely cause of his current symptoms? Have A, DIARRHEA lesions, B, gastroparesis, C, pyloric stenosis, D, peptic ulcer disease, E, Mallory West tear. Anybody can just shut out the answer. D. So looking at the incorrect answer choices, DIARRHEA lesion is an uncommon cause of upper GI bleed. It's usually diagnosed on endoscopy. It's a bleeding artery on the lesser curvature of the stomach. Gastroparesis has nothing to do with bleeding. Is usually related to hindered emptying of the stomach. Pyloric stenosis, mostly seen in male infant around the newborn period, that presents as projectile vomiting. And Mallory West tear, these are tears around the gastroesophageal junction that's related to alcohol intake, sometimes bulimia, because this patient have intractable nausea, vomiting, they're retching. Like any differential under the arsenal of upper GI bleed, they can present with hematemesis or melena. But given the clues found in the vignette, namely the chronic use of over-the-counter pain medication in the recent course of steroid, peptic ulcer disease is most likely a better answer choice. So with that, we're going to talk about GI bleed. Divided into two categories. We have upper GI and lower GI. Both are divided by this ligament. The ligament of Treitz found somewhere towards the end of the stomach and between the first two portions of the duodenum. So anything distal to that ligament is lower GI bleed. Some of the predisposing factors include chronic use of NSAID salicylates, and some of the common causes include diverticular disease, colitis, bleeding polyps, malignancy, hemorrhoids, and anal fissures, among other things. Terminology to keep in mind when we think about lower GI bleed include hematochezia, which is pretty much bright red blood per rectum that has a strong association with lower GI bleed. Sometimes upper GI bleed with rapid transit through the GI tract can present as hematochezia. I don't think that's very common. Another thing also is clots per rectum, which means just that the patient is bleeding from the lower GI bleed. Upper GI bleed then is anything above the ligament of Treitz. And again, predisposing factors, we have NSAID salicylates, alcohol use, steroid use. Common causes, we have peptic ulcer disease that accounts for more than 50% of all upper GI bleed. Then there's erosive gastritis, esophagitis, bleeding varices, and Mallory West tear, among other things. Common terminology, we have hematemesis, which pretty much means vomiting blood. And sometimes, depending on how much blood the patient is vomiting, they require intubation and or urgent endoscopy to pretty much control the source of the bleeding. Something to keep in mind is that sometimes swallowed blood from posterior epistaxis can also present as vomiting blood. So we need to differentiate where the blood is coming from. Another thing is coffee ground emesis, which like hematemesis means vomiting blood. The difference is that the color is darker, which means blood has had time to kind of congeal in the stomach, hence pointing a little bit to a less active or slower bleed. Another thing is melena, which is pretty much dark or tarry stools, points to upper GI bleed, again, as can be inferred by the color, meaning that blood has had time to transit through the GI tract. Something to keep in mind is that sometimes a right-sided colonic bleed with a slow transit can sometimes present as melena as well. Our other question is, 49-year-old male, past medical history of non-alcoholic steatohepatitis, complicated by ascites, presents to emergency department complaining of increasing abdominal discomfort and pain. Upon further questioning, his wife at bedside adds that she has noticed intermittent confusion the past 2 days, as well as fever with Tmax of 39.2 centigrade. Which of the following is the best initial management for this patient condition? A, dietary changes, B, lactulose, C, phlebotomy, D, transplant, or E, cefotaxime? E, yep. So this patient is pretty much presenting with SBP, which is one of the most common life-threatening complications of patients with ascites. And the current recommendation is antibiotics with one of the third-generation cephalosporins, to which cefotaxime belongs. Looking at some of the incorrect choices, A will be appropriate for any patient with a new diagnosis of NASH. Lactulose is more used in encephalopathy, where you have a buildup of nitrogenous waste. Phlebotomy, that's a treatment for hemochromatosis, and transplant is appropriate management for any patient with end-stage liver disease. So thinking about SBP then, this is an acute infection of acidic fluid in patient with liver disease in the absence of another cause. So it's kind of a diagnostic exclusion. Symptoms, we think sometimes of a classic triad that is rare. Fever, abdominal pain, increasing ascites. But the most common presenting symptoms include fatigue, fever, chills. These people complain of just being uncomfortable because of the increasing of the abdominal girth. They can be tender to palpation with rebound and guarding. This patient required to be tapped and antibiotics. So you will do a diagnostic paracentesis, and requirement for diagnosis, you can have a neutrophil count greater than 250 or white blood cells between 250 to 500. And people undergoing a peritoneal hemodialysis, the criteria requires greater than 100 millimeter cubes of white blood cells with greater than 50% polymorph predominance. Or they can also have a neutrophil count greater than 100. As far as treatment goes, we are pretty much treating gut bacteria. So mostly gram-negative, and we can also have gram-positive there, mainly E. coli. So any third generation cephalosporin would be a good choice, with ceftriaxone and cefotaxime being mostly used with the dosage listed up there. Our third question, we have a 28-year-old obese female construction worker that presents with sudden onset right lower quadrant abdominal pain after lifting boxes just prior to arrival. On exam, there's a bulge just inferior to the inguinal ligament. There's no bulge in the inguinal canal. The patient is placed in reverse Trendelenburg, and the hernia is reduced manually with resolution of symptoms. What is the next step in management? A, discharge home with over-the-counter pain medication. B, CT of the abdomen. C, ultrasound of the femoral and inguinal region. D, observation for at least 4 hours. And E, surgical consultation. I hear E, good. The correct answer is surgical consultation. So this patient is presenting with a femoral hernia, which is prone to complication. He has about 10 to 1 female prevalence, and he also carries a respectable risk for mortality. Because of that, the current recommendation is in-house surgical consultation, or at least a reliable, urgent outpatient follow-up if surgery is not available in-house. So talking about hernias, there are many different types: umbilical, epigastric, and incisional. The ones I want to focus on today are inguinal and femoral. The inguinal hernias lay above the inguinal ligament. You have the direct inguinal hernia that pretty much protrudes through a weakness in the transversalis fascia into the Hesselbach triangle. The indirect hernia traverses through the internal inguinal ring and protrudes as a scrotal mass after exiting the external inguinal ring. And they are the most common type of hernia and mostly found in male. Femoral hernia, on the other hand, located below the inguinal ligament. You have, again, the female prevalence, 10 to 1 ratio. When palpable, they are located lateral to the inguinal ring and infralateral to the pubic tubercle. Again, they are prone to complication, with most of them presenting as incarcerated or non-reducible or strangulated with necrosis and compromise of the vasculature. So they also carry a high mortality rate, and to about 10%. We are in patients with delayed repair. So the recommendation is surgical consultation in the emergency room, or arrangement of reliable, urgent outpatient follow-up. A 33-year-old female presents to the ED with complaints of severe pain with swallowing and inability to read PO for 1 week. Her past medical history is significant for cystic fibrosis, bilateral lung transplant 3 years prior. She denies any other medical issues and is compliant with all her medications. She has been trying over-the-counter acid suppressants without relief. Her pertinent finding exams are shown in the picture. What is the most appropriate treatment? A, acarfate, B, encyclovir, C, fluconazole, D, famotidine, or E, pantoprazole. The correct answer is C. Looking, this patient is pretty much presenting with Candida esophagitis, and fluconazole is a good antifungal with activity against yeast, so it's currently the treatment of choice. Looking at some of the incorrect choices, acarfate will be useful in erosive gastritis, and encyclovir is the management for a CMV, esophagitis. Famotidine and pantoprazole are used more in acid reflux, so they have no advantage or no use here. So thinking about esophagitis, it's pretty much inflammation of the esophagus, and there are many causes. You can have inflammatory, infectious, with common culprit being Candida, HSV, and CMV. Something to keep in mind is that these are AIDS-defining lesions, especially Candida. So you have a patient that presents with thrush or Candida esophagitis without known cause for immunosuppression. They may benefit from HIV workup. Other causes include pill esophagitis with antibiotics like doxycycline, clindamycin, and pain reliever like NSAIDs and aspirin. Clinical features will include things like odynophagia, dysphagia, chest pain, nausea, dyspepsia. The diagnosis is largely clinical. They will have characteristic lesions. If it's unclear, they may benefit from an outpatient EGD to pretty much identify the cause. Management, if they are severely dehydrated because they've been throwing up or not eating, you can hydrate them, give them good pain control. And as far as targeted treatment, if a patient is presenting with Candida esophagitis, the treatment is fluconazole, HSV, valacyclovir, CMV, we benefit from, again, cyclovir. A 63-year-old man with, sorry, how do you move? There we go. A 63-year-old man with past medical history of hypertension, diabetes, cholelithiasis, presents with fever, abdominal pain, and vomiting for the past 2 days. Today, his wife brought him to the emergency department because he was confused. His vital signs are he's tachycardic, hypotensive, and febrile to 39 centigrade. On physical exam, he appears jaundice and his abdomen is tender in the right upper quadrant. Which of the following is the most likely diagnosis? A, acute cholecystitis, B, biliary atresia, C, biliary colic, D, Fitzhugh-Curtis syndrome, or E, ascending cholangitis. Is it? David? What did I do? Is it because this one?
Yeah, the arrows down.
So the correct answer is ascending cholangitis. The patient in the vignette meets all the criteria for renal pentad, which pretty much groups the common presenting factors of or symptoms of ascending cholangitis, which is life-threatening inflammation of the hepatobiliary tract. And looking at the David. What is it? Is it because I minimized this? Okay.
Click those. Okay.
Okay. So talking about biliary disease, the disease process pretty much depends on where the insult is in the hepatobiliary tract. So you can go from biliary colic, which is pretty much a symptomatic stone that intermittently gets stuck in the neck of the gallbladder, to acute cholecystitis, where you have a superimposed inflammation. Something we don't necessarily see a lot of in the EDs, a calculous cholecystitis, which can be thought of as a paralytic ileus of the gallbladder. These patients are very sick, usually found in the ICU, and it's dangerous because it's prone to perforation and gangrene. Another important thing to keep in mind here then is cholangitis, which is pretty much an obstruction with a superimposed infection of the common biliary duct. And some of the causes, we have people with stones, malignancies, and the bacteria found usually originate from the stomach, things like E. coli, Klebsiella, Enterococcus. As far as the clinical features go, you have a triad and a pentad. Charcot triad, you have right upper quadrant pain, fever, jaundice. Renal pentads then is Charcot triads plus shock, as in altered mental status and hypotension. Management for these people, definitive management is ERCP, which is both diagnostic and therapeutic. If unavailable, some patients can benefit from percutaneous surgical drainage. In the ED, our job is really to well resuscitate these patients, so IV fluid and antibiotics until they are admitted. A 47-year-old male is brought to the emergency department by EMS with complaints of 10 abdominal pain, nausea, profuse vomiting, and subjective fevers. Report his symptoms started 3 days ago after a week-long alcohol binge. Physical exam is significant for epigastric tenderness, palpation, and skin discoloration as depicted in the picture below. Which of the following is the most likely diagnosis? A, gastritis, B, pancreatic adenocarcinoma, C, peptic ulcer disease with perforation, D, necrotizing pancreatitis, E, traumatic duodenal hematoma. The correct answer is D, necrotizing pancreatitis. So looking at some of the incorrect choices, gastritis will present with tenderness to palpation at the epigastrium, especially if they have a history of alcohol binge, but that will not present with the Cullen sign seen in the picture, which is pretty much superficial bruising or edema that signify hemoperineum. Pancreatic adenocarcinoma, this patient usually presents with painless jaundice. We have other things like weight loss, early satiety, and the like. Peptic ulcer disease will have tenderness palpation at the epigastrium, but perforation will also present with peritoneal sign, which this patient does not have. And as far as traumatic duodenal hematoma, that requires trauma. There's no mention of trauma in this vignette. So talking about pancreatitis, when you have a patient with past medical history of alcohol use, gallstone, hypertriglyceridemia, the use of certain medication like hydralazine, and a complaint of abdominal pain, characteristic finding exam of the epigastric to left upper quadrant abdominal pain radiation to the back, a suspicion for pancreatitis should be high. So some of the clinical presentation include persistent intractable nausea and vomiting, just people in a lot of pain. It will be tender to on exam, epigastric radiation to the back. Some things that can sometimes be found on exam, Dr. Sinnott said he never saw it. Cullen and Gray Turner signs are pretty much superficial bruising or edema that signify hemoperineum that can be found around the umbilicus for Cullen and around the flanks for Gray Turner signs. And they are associated with the late findings of severe necrotizing pancreatitis. So when it comes to the diagnosis of pancreatitis, we require really 2 out of 3 criteria. You can have a lipase greater than 3 times the upper limit of normal, so in the 300, 400, 500s. Characteristic abdominal pain, epigastric radiation to the back, and or imaging evidence of struggling pancreas. Thing to keep in mind is that imaging is not required for the diagnosis of pancreas, but it can be important in risk stratifying these patients, especially patients that come in very sick or become very sick later on in the course. As far as the type of pancreatitis, there are really 2 big categories. The one we see more often is edematous pancreatitis, which is pretty much a diffuse inflammation of the pancreas that maintain viable tissue. These patients you generally do well on the floor, keep them MPO, hydrate them, control their pain well, give the pancreas some time to recover. A subset of these patients develop severe acute pancreatitis, which is pretty much pancreatitis that causes organ failure that lasts for more than 48 hours. And the other category is necrotizing pancreatitis, where you have areas of non-viable tissues as seen on the CAT scan. So these latter patients require at least an ICU consult and admission to the ICU because they can go in shock and they require aggressive management. We have a 42-year-old female with a past medical history of bipolar disorder and depression that is brought to the emergency room by EMS after she was found sitting in front of the kitchen sink, drinking household bleach in a suicide attempt. Initial exam, the patient is able to share her name, speak in full sentences, and is tolerating her secretion without sign of airway compromise or hoarseness. Her vital signs are within normal limits, and there is no tenderness to palpation in the chest or epigastrium. Which of the following is the best next step in the management of this patient? A, activated charcoal. B, broad spectrum antibiotics. C, dilution with milk. D, GI consultation for endoscopy. Or E, intravenous PPI. So this patient is presenting pretty much with an acute alkali ingestion with concern for development of airway compromise and esophageal injury. So GI consultation for endoscopy to pretty much visualize and assess the extent of the injury is warranted. So looking at some of the incorrect answer choices, activated charcoal does have its place in toxic ingestion, pretty much decontaminate the stomach, but alkali substances ingestion is not one of those substances where charcoal has a benefit. Broad spec antibiotics can be useful if there's a concern for perforation. Dilution with milk, no, because this patient is supposed to be kept NPO. And intravenous PPI can be beneficial if there's concern for a GI bleed. So talking about caustic ingestions, caustic substances are pretty much any substances that cause damage upon contact with body surfaces. And these are divided into two big buckets. We have alkali and acids, and the degree of injury these substances cause is determined by their pH, the concentration of the substance, the volume ingested, and the duration of contact with body surfaces. So alkali substances are more dangerous or concerning because they cause liquefactive necrosis with deeper injury and are prone to perforation. Some of the examples include drain cleaner, grease remover, hair relaxer, among other things. And acids, they cause coagulative necrosis, and they have a propensity to form eschars, so their injuries are more superficial. And some of the examples include drain opener, pool cleaner, and rust removers, and the likes. As far as the clinical features, presentation will revolve around the signs of airway compromise and esophageal injury. So you have patient dysphagia or dinophagia, drooling, inability to tolerate their secretion, nausea, and vomiting. You can also have things like dysphonia, stridor, respiratory distress. When it comes to management, this patient needs to be placed NPO and monitored closely for kind of signs of impending airway compromise and or esophageal injury. If a patient appears to be in distress, they need to be intubated, and they need to be scoped somewhere between 24 and 48 hours to properly assess the extent of the damage. If there's a complication as in perforation that will present as mediastinitis or peritonitis, surgery needs to be involved. And there is also specific caustic substance targeted treatment. Hotline or with poison control, it's a good resource to pretty much help guide you through the management of these patients. We have a 56-year-old man with a history of hypertension that presents with rectal pain that has been present for a few days. He reports dull throbbing pain that constantly worsen with defecation. His vital signs are remarkable. On examination, a superficial erythematous tender fluctuant mass is noted close to the anal verge. A CT abdomen reveals a fluid collection in the superficial perianal space. Which of the following is the most appropriate management? A, admission for IV antibiotics. B, insertion of a ward catheter. C, marsupialization. D, incision and drainage in the ED. E, surgical consult for drainage in the OR. The correct answer is D, incision and drainage in the ED. The patient is pretty much presenting with a perianal abscess that can be appropriately managed in the emergency room. Looking at some of the incorrect answer choices, Admission for antibiotics is not warranted unless the patient appears very sick and has other risk factors like they're older, they're immunocompromised, they have diabetes and the like. Insertion of a wart catheter, that's the management for a battling cyst, and marsupialization is the management for a pilonidal cyst. As far as surgical consult for drainage in the OR, that's the management for perirectal abscesses. So looking at anorectal abscesses, there are pretty much two big types. Perianal abscesses refer to an obstruction or infection of the anal crypt with the associated gland. These infections are usually polymicrobial. Risk factors include diabetes, IBD, immunosuppression, chronic steroid use. Symptoms, they present with pain, worse with sitting or defecation. The diagnosis is largely clinical. You have a superficial, tender, fluctuant mass around the anal verge. Treatment, incision and drainage in the emergency room. You can make a linear incision and follow that by packing just to keep the abscess open, or you can make a stellate or elliptical incision just to keep, again, the abscess draining. The use of antibiotic is somewhat controversial. Some people antibiosis people, some don't. If they are elderly, they have a history of diabetes, they're immunocompromised, or there's a surrounding cellulitis. Those patients can benefit from a course of Augmentin or Cipro plus Fragile. As far as perirectal abscesses go, these are an infection of the deeper potential spaces around the rectum. The risk factors are similar to perianal abscesses. Symptoms, pain, and they can also present with some systemic signs of fever and chills. And if blood work is sent, they can have a leukocytosis. The diagnosis, sometimes these abscesses can be palpated by DIARRHEA, but a CT abdomen is needed to pretty much identify the extent of how deep these abscesses are extending. Treatment is, they require a surgery consult because they need to be drained in the operating room, and they will benefit from IV antibiotics as well. A 42-year-old man without significant past medical history is brought in by EMS for first-time seizure. EMS did not administer any medication en route. His spouse says they both have had bloody diarrhea and fever since sampling food at the farmer's market 2 days ago. Her description of the seizure is consistent with generalized tonic-clonic seizures lasting less than 1 minute. The patient speaks to you weekly, answering full sentences, and his vital signs are notable only for tachycardia. Which therapeutic agent should be started in the ED? A, ciprofloxacin, B, midazolam, C, Keppra, D, doxycycline, or E, metronidazole. The correct answer choice here is Cipro. This patient is presenting with dysentery or bloody diarrhea with seizure. This is a common presentation for shigellosis, which is a foodborne illness. The current recommendation is to antibiosis people. Looking at some of the incorrect answer choices, Keppra, midazolam, well, if the patient kept seizing, they may benefit from a dose of midazolam. If they needed to be loaded for whatever reason, Keppra might be helpful. Doxycycline would be a good choice for dysentery caused by Vibrio vulnificus or Brucella species, which do not present with a seizure. And metronidazole would be a good treatment for Giardia, Entamoeba histolytica, or C. diff, which also do not present with seizure. So, thinking about dysentery or bloody diarrhea, I wanted to touch on shigellosis and enterohemorrhagic E. coli. Shigellosis is a foodborne illness. It's transmitted via fecal-oral route, and association is usually with raw vegetables and in small kids' daycare attendance. It has an incubation period of about 2 to 6 days with a duration of symptoms of about 5 to 7. Symptoms have profuse bloody diarrhea, abdominal pain, cramping, nausea and vomiting. They can have really high fevers. Some patients can present with altered mental status, seizures, especially in the pediatric population. The recommendation is to antibiotics these people with treatment of choice being anybody in the family of the fluoroquinolone. Looking at enterohemorrhagic E. coli, Transmission is the same, fecal oral, raw vegetable milk, some meat products. Incubation is about 2 to 5 days and with a 5 to 10 days duration. Symptoms, bloody diarrhea, abdominal pain. They can also have very high fevers. Treatment for this dysentery, however, is supportive mainly because antibiosing these people can make them prone to developing TTP and HUS. So of all the bloody diarrhea presentation, enterohemorrhagic E. coli is one of the few that no antibiotic is recommended. So I have a table here with some of the bloody diarrhea and their causes and some of the management as well. So we have a 3-year-old male without significant past medical history that presents to the emergency room after his parents saw him swallow a single button battery. The child has normal vital signs for his age. On exam, he's playful and eating crackers. Exam is otherwise unremarkable. An X-ray shows a single 1 centimeter diameter battery in the stomach without other acute pathology. What is the best next step in management? A, EGD within 1 day. B, EGD within 2 hours. C, gastroenterology outpatient referral. D, observation for 6 hours in the emergency department. Or E, repeat X-rays in 1 to 2 days. The correct answer is a repeat X-ray in 1 to 2 days. And we're going to talk about management of ingested foreign bodies in the emergency room. So when a patient presents with an ingested foreign body in the emergency room, the management really depends on a couple of things. First, like in everything we do, patient status, stable versus unstable. Then things like the characteristics of the object come into play. You have the type, if it's a button battery, that changes things, the size of the object, the shape, whether it's sharp or not, and then the location of said foreign body, where it actually sits in the GI tract. And this becomes particularly important for button battery because they are prone to causing necrosis if they're lodged in the esophagus for as little as 2 hours. So in a patient that presents with foreign body ingestion, the first step, like in everything we do, is assess them. If they are symptomatic in any way, they require urgent endoscopy, whether it be GI to look at the esophagus, or whether it be ENT, if there's a worry that the patient may have aspirated that object. So if the patient is otherwise stable, the management then depends on location. If it is pre-gastroesophageal junction, they will benefit from an EGD removal urgently in the emergency room. If GI is not available in-house, they can be obs for 24 hours with the intent to scoping them in the morning or something like that, or when GI presents in-house. If the object is then past the gastroesophageal junction, it will depend again on the characteristic of that object. If it's sharp and it's located in the first 2 segments of the duodenum, then it warrants an EGD removal. If it's past the first 2 segments, then an X-ray every day for up to 3 days. If there is no progression of the object, then it warrants an EGD removal. If the object is large and it is in the first 2 segments of the duodenum, then it must be removed. If it's past the first 2 segments, then it must be removed at 1 week if there is no progression. If the object is small, the patient will benefit from an X-ray for up to 3 to 4 weeks. If the object is pre-pylorus, then it must be removed via EGD at 3 to 4 weeks if there is no progression. If it's past the pylorus, it must be removed at 1 week if there is no progress. And then when it comes to button batteries, if the button battery is past the esophagus, the patient will benefit from an X-ray at 2 days to assess for progression. If it's still pre-pylorus, then an EGD removal is warranted. If it's post-pylorus, then X-ray every 2 to 3 days. If there is no progression, then EGD removal at 1 week if there's no progress. So that concludes topic review.